Yep. So we'll get started. It's 12:10. Welcome all to Grand Rounds program at Mary Greeley. Today I have the pleasure to introduce Dr. Dan Fulton. Dr. Fulton is my partner in the Department of Infectious Diseases, and he joined McFarland Clinic in Mary Greeley in September of 2015. He's already a people's favorite due to his personal qualities and excellent medical knowledge. Dr. Fulton completed his undergrad in biology and Spanish, and I'm just learning that's how he masters Spanish, in Iowa State. Then he did his medical school in University of Minnesota. He did his internal medicine residency in Hennepin County in Minneapolis, and he completed his infectious diseases fellowship in University of Iowa. He served also as chief medical resident in Hennepin County. Today he's going to talk to us about central nervous system infections, and one special point to pay attention to is a new PCR testing that we have available, and lots of other interesting points. So without further ado, I leave you with Dr. Fulton.
Thank you, Dr. Arbalou. Well, so I'm Dan Fulton, and I was really excited to get to come back and give another Grand Rounds. I think this topic is really interesting and sort of very timely, as you'll see with some of the new technology that we're bringing on board just recently. And the interesting thing about any infection, I think, is that ultimately it's infecting someone, and so throughout preparations for this and the cases that I'll be sharing with you, I just want to remember that the people that are affected, these infections really come out of nowhere, and people aren't in any way prepared for them. And I think this is a famous case of meningitis that's often cited as sort of a case study in how severe these infections can be in cutting otherwise healthy person's life short. Oscar Wilde was died from probably streptococcal meningitis at the young age of 46, right as his career was reaching a peak in terms of his literary and sort of playwright career. The types of infections that people can get in the central nervous system are broad. They vary. There's, I think, around, well, I don't know how many, hundreds of them. When I was talking with my wife before the presentation, she suggested that I just go through each one by one, but we decided that wouldn't work and it'd be boring, and then we decided maybe we should just show clips from Star Wars instead. That'd be more interesting, but we wouldn't learn as much. So I wanted to just put this is sort of an outline of, I think, some of the more common things that are encountered both in clinical practice and potentially on the news and in other areas. So we'll be focusing on a few of these. A couple that we won't be focusing on as much are, we won't be looking at abscess lesions as much. In general, those are post-operative and often require neurosurgical care. So most of those patients will be transferred to a place that has neurosurgery available. The exception to that might be an epidural abscess, which I think, depending on its location, we might be able to take care of here. But in general, most of those infections will go elsewhere. And then many of the sort of hardware and surgery-associated central nervous system infections we won't be seeing too much of here. We're not going to hit all of these. We'll try and hit some of the main ones. But if you had questions about any in particular, we could certainly talk about those as we go. So I wanted to start, before we get into the cases, with just a couple broad outlines about CNS infections. Unlike, say, a cellulitis, where if there's pus, the pus just sort of can drain, the brain is sort of in this enclosed space, for good or for bad. So there is obviously the skull on the outside, and then there's these layers of sort of protective tissue called the meninges, which I think are probably very useful for us evolutionarily because they keep bad things out. You know, every time you brush your teeth, you get a little bacteria floating in your blood, and your immune system has to take care of it. So for very important spaces like your brain, it's good to have a little extra protection. But if things go bad, you have that much less time to sort of get it right. So in general, if a CNS infection is on the differential, you need to be aggressive in both the workup and the treatment. And these cases are often very multidisciplinary between multiple different physicians and also nursing and then therapies as people are starting to recover. So given that list of hundreds of different types of infections, I think another sort of broad thing to think about is how fast the symptoms come on. So if somebody has symptoms over the course of 3 to 4 days, less than a week, I would think of that as more acute. And those are sort of classic bacterial meningitis from Streptococcus or Meningococcus, and then viral meningitis or encephalitis. And those things particularly need very rapid evaluation and empiric treatment. If it's been going on for 1 to 2 weeks, then you start to have to broaden out the way you think about it, because most people with strep meningitis, if you didn't do anything, they wouldn't live longer than a week. So if it's been going on longer than a week, start thinking about more atypical types of infections like you see here. And then if somebody comes in saying that they've had progressive symptoms of headaches, neck stiffness, fevers, sensitivity to light, classic meningitis type symptoms, and it's been going on for weeks, you really need to broaden out even further into the types of things that are very slow moving, and certainly there would be non-infectious causes on this list as well, but these would be the main infections. I always say when I'm thinking about infections that you need to know your OATS. This was a mnemonic that was taught to me by one of our HIV providers at Hennepin County, and it's a way to just remember which things that, if you're thinking about infection, it's really about the ecology of what the person might be surrounded with and exposed to, and this is just a nice way to remember it. So you should always try to know what the patient does with themselves during the day in terms of their occupation. You should know if they have exposure to specific animals, both pets, and then did they recently pick up a dead raccoon on the side of the road? What sorts of activities do they like to do? Are they water skiers? Are they traveling to northern Minnesota in the summer? Have they traveled outside of the country? And then certainly sexual history and shooting up, which is an allusion to HIV. And with that sort of notion of HIV, I think knowing somebody's general immune status is also very important. So we do see a lot of people on chemotherapy here, and I would see them as at much higher risk for atypical infections than other people. So as far as the raccoon goes, if you're wondering what infections might be raccoon-related, one might be rabies if you got a bite. The other more obscure one would be something called Balis ascaris procyon. It's a worm infection that infects primarily children. It turns out raccoons use a latrine, so a raccoon always poops in the same place. And so if a child sort of gets into that and sort of looks around and maybe eats some of the dirt, they can get this weird parasite. Which is a little bit of a clue, which I'm not going to cover anywhere else, so I'll mention it here. If you have eosinophils in your spinal fluid, that's a sign that something weird is going on. So those are usually fungus or parasites and would warrant sort of a different approach with maybe a wet prep of the spinal fluid and different fungal testing. So if you ever saw that on a spinal tap, that's something we'd request you give us a call, because that's into the realm of zebras and weird things. So. This is the notion of water skiing here in northern Minnesota. Perhaps you've heard of this organism called Naegleria. It hits the news a lot because it causes a fulminant, horrible meningitis, predominantly in teenagers because they go swimming and diving and fresh water gets up their nose, and then this amoeba goes into their brain, and it's difficult to treat. So if somebody came in with a really bad meningitis and you didn't ask them if they'd been on vacation recently, and you wouldn't ever think of it. So it's important to ask those types of things. That's the amoeba. Another thing that I think that I'm not going to cover in another place, but I think is important to note, is that one of the common presentations of acute HIV seroconversion is aseptic meningitis. And I've seen this missed multiple times because the causes of aseptic meningitis are so varied that the routine testing is negative, and then the person recovers. They now have HIV, and then they're not diagnosed for another 8 years when they come in with their cryptococcal meningitis or something else. So I would say, particularly in a young person, knowing their risk factors for HIV is important, and having a very low threshold for screening is also very important. I got an interesting call the other day about a patient in Marshalltown who had basically developed a rash over their left eye, and it looked for all the world like zoster infection, and the patient was in the right age category, and the spinal fluid was pending, but the patient was very sick with what looked like meningitis with maybe a little bit of encephalitis, and heard the story, and the question was sort of like, well, why isn't the patient getting better, and do we need to do anything else? So I started asking about knowing my OATS, and so it turned out that the patient had just come back from a 2-week vacation to Thailand and had not gotten any of their vaccines or taken any prophylaxis, which you can imagine hugely broadened out the number of possibilities that we had to worry about. Fortunately for that patient, it was zoster, and that was the end of it. But if it hadn't have been, we'd have to worry about things like Japanese encephalitis or malaria or dengue as potential causes of meningitis. So we do have some guidelines to lean on when we're trying to think what might be the best care for folks. The bacterial meningitis guidelines are getting older now, so they're in the process of being updated. They are going to split these out because they're really different things if you get meningitis in the hospital after a procedure versus if you come in from the community. So they're planning to update the hospital-acquired first and then do the community-acquired, and we'll talk a little bit about the differences. The management of encephalitis and Lyme disease are also getting a little bit older. But I would say ultimately, if you look at the level of evidence that a lot of these guidelines are based on, it's a lot of level C, level 3 type evidence where it's based on clinical experience without a lot of data, because you can imagine that these cases are pretty sporadic, they're pretty severe, and it's really hard to conduct clinical trials under these circumstances. So we'll try and talk about some of the bigger trials that have been done, but a lot of the evidence that these guidelines are based on is not strong evidence. So thinking about what causes bacterial meningitis, and one reason it's important to update guidelines from time to time is that the epidemiology does change. So for example, here you can see that H. flu used to be the most common cause of bacterial meningitis, almost half of all cases, and then the H. flu vaccine came out for kids, and now H. flu is really not causing meningitis anymore. Similarly with meningococcus, that used to be the number 2 cause of meningitis in the US, and it's since been surpassed by strep, probably because of the meningococcus vaccine. And listeria and some of these other infections are not necessarily going up over time, but as these other ones have dropped off, their percentages as a portion of the whole have gone up. So I alluded to just general empiric therapy. There's a couple things that I wanted to bring up in terms of when you're thinking about treating somebody with meningitis, just initial thoughts. You can see here, this is from the Johns Hopkins guideline for antibiotics, that there's an age cutoff and there's sort of an immunocompromised sort of cutoff. And so if you're less than 50, the recommendation is that you get ceftriaxone and vancomycin. And we'll talk about why. If you're more than 50, the ampicillin gets added in to cover specifically listeria. Neither of those other two antibiotics cover listeria well. And when we've looked at epidemiologic surveys of listeria, it generally causes disease in people over 50. It can cause diseases in people under 50, so you occasionally might hear of outbreaks of listeria in like ice cream or hummus or these sort of things that are unfortunate. So certainly under an outbreak circumstance, you'd want to break this rule, or if there was something that seemed fishy about the case, you could potentially add ampicillin as well. But in general, over 50 is when you start adding ampicillin. I would also say that from a practical perspective, when we're dealing with wanting to treat rapidly, that you get the most bang from your buck with ceftriaxone. The vancomycin is really there as an adjunct, and so if you had to pick one versus the other to give first through your one IV line, like if both orders come through at the same time, I would always start with the ceftriaxone because that's the better coverage. And I've seen a couple patients where the vanc was started and then the IV got lost, and then we monkeyed with the IV for a while, and finally the IV got in, and then we finished the vanc, and it was 4 hours before the ceftriaxone went in, when really you can give ceftriaxone IM times 1, and it's probably almost as good. So just as a note, ceftriaxone is probably the best drug overall. And then if you're immunocompromised, or if you've had recent surgeries, or you have any sort of hardware, that's where you change the ceftriaxone to cefepime. Basically, you want to add coverage for more resistant gram-negative rods, which I think here would be pretty rare because we're not doing a lot of manipulation of people's CSF. But for example, some of the chemotherapy patients that may be getting intrathecal methotrexate or had recent LPs, if they show up with all of a sudden a bad meningitis, you'd want to use cefepime instead of ceftriaxone. Okay. The other thing to think about with infections from the big picture perspective is that that same covering of the brain that is protecting us from all of these bad infections unfortunately also protects us from the antibiotics we try and give. And so there's these sort of what are called tight junctions. That's the classic blood-brain barrier that you might have heard of. So these are there to specifically keep things out of your brain, but that unfortunately includes things like vancomycin and maybe some of the other antibiotics. So in general, the smaller the drug, the more sort of fat-loving it is, and the less protein-bound it is, the more likely it is to get into that space. Practically speaking, what that means is we just have to updose a lot of our drugs. So ceftriaxone, we end up giving 2 grams Q12, which is a lot higher than usual. Ampicillin is 2 grams every 4 hours. And the bummer with that is you're more likely to get toxicity and side effects. So I think the main ones to note are the cefepime is 2 grams every 8 hours. Ceftriaxone is 2 grams every 12 hours. And then going back a slide, it turns out quinolones are really good at getting into the spinal fluid because they're relatively small drugs. And so they're sort of a good alternative if you've got a penicillin allergy and you don't actually have to change the dose that much. So I'd like to move into the cases now. These are all patients that I've actually cared for fairly recently. So this patient was a really nice 62-year-old lady who worked in a flower shop, and she started feeling bad one day, and so she went home early in the afternoon, and the next morning she didn't show up for work, which was really uncharacteristic of her. And so they called her, and she didn't answer, and so somebody went out to her house to basically check in on her, and they found her face down in her living room. So no other history was known, but she had a fever, her heart rate was up, and she was a little hypotensive, but that got better with some fluids. 2 things I really remember about her is that she had the most incredible halitosis I'd ever experienced. You could smell her breath from the hallway, and she also had this lacy blue skin changes, which is sometimes called livido reticularis, which just means lacy blue skin changes. And it basically is a sign of low blood pressure and venous stasis. So she was sick, basically. And the other thing we noted was that she was obtunded. She was totally out of it. And I thought that she had some limited range of motion in her neck. So like most patients over 60, when they come in really sick, it's hard to get a urine sample. So in her, they got one, and it showed some white blood cells, but a lot of squamous cells in it too. And so the initial presumption was that this was a bad urinary tract infection. So I think I spoke with that resident in the emergency department and really pushed for sort of evaluation for CNS disease. So do you guys have clickers? People have clickers. So this is our first question, 1, 2, or 3. So if you are worried about CNS disease in a lady like this who's obviously sick, had some hypotension, what do you want to do? Do you want to send her for a head CT? If it's not showing anything bad, do the LP, and then if the LP is positive, give her these antibiotics. Do you want to give her some steroids and one of the antibiotics, then get the CT and the LP, and then add antibiotics? Or do you want to just go give her an LP as quick as possible, and then if it's positive, give antibiotics? So you have, I think, well, that didn't work. Well, so think about that. So the question here, what it's trying to get at is 2 things. When do you need to get a head CT? And then what's the timing of the antibiotics? So these are the guidelines from 2004. So do you have suspicion for meningitis? Yes, we do. Is she immunocompromised? We don't think so. Does she have a history of CNS disease? No. Does she have a focal neurologic deficit? Well, we don't think so, although she's obtunded. And the one thing they don't include in here is she over 60, which she is. So any of those things make you want to first get a head CT to rule out that they don't have a mass or something. The risk is if you take spinal fluid out and they have a mass, they could herniate from the differential in pressure. So she does need a head CT before she gets her lumbar puncture. So if that's the case, the recommendations are that you get your blood cultures and then you go down this pathway. You need to get a head CT, but before you get the head CT, you need to give steroids and that ceftriaxone as soon as possible, because basically time is brain. Every minute that you wait is a trade-off in terms of treating the infection. So the trials that have been done basically say don't get the CT because there's inevitable delays before getting the antibiotics. So just give your antibiotics and your steroids, then get the head CT, and then if it's negative, you can get your lumbar puncture. If, on the other hand, the patient is 23 and has a fever and a headache and is otherwise totally fine, you don't necessarily need a head CT. I would be interested to hear from anybody in the ER if they, if this is typical, or because a lot of this data is from an era when head CTs were not quite so easy to get, and you couldn't get one in 5 minutes, So anyway, these are the guidelines, but Leanne, did you have a comment? I'm really glad. I promise I didn't plant you, right? That's a really good question. So the answer to that is shoot first, ask later. So you want to. It's basically not worth the trade-off. You are going to lose some LP sensitivity with that. So in this study, they looked at if you got the LP within, for example, 2 hours, you were still able to find meningococcus. If you got it within 4 hours, you were still able to find meningococcus and strep pneumo. This is the culture. If you got it even within 8 hours, you could still find some of these things, but anything over 8 hours, you would lose it. So if you think about a standard ER situation, somebody comes in, you can give the antibiotics, get a head CT, and you're still well within these windows of not losing your culture sensitivity. But you might lose some. So I think that's a great question. So in this patient, she does have a lumbar puncture, and this is a table we're going to come back to several times. So she had 8,500 PMNs, low glucose, and high protein. So this is from the guidelines also. So bacterial meningitis should have a lot of white blood cells that are PMNs. Glucose should be low, and protein should be elevated. So she's in the bacterial meningitis situation, and this was her gram stain. So look at that for a second. You might notice that they're pink and that there's two of them together. I think that's the best one. So what would you do now? I think this time we're going to do this so you can do your poll. Would you give her vanc, ceftriaxone, ampicillin, and dex while you're waiting for the cultures? Would you give her ceftriaxone and the dex only, or would you give just ceftriaxone? So you probably noticed that this is Neisseria meningitidis. It's a gram-negative diplococci. I see the micro folks here. I like to look at gram stains. They're very welcoming. If you ever want to look at gram stains, you can go down and they'll bring them up and show them to you. And thank you guys for always letting me come poke around. So, so you should continue vanc, ceftriaxone, ampicillin, and dexamethasone. You should continue ceftriaxone and dexamethasone or just the ceftriaxone. So this is sort of getting at what's the treatment for meningococcus, and the treatment is ceftriaxone. So because you have a positive gram stain, you wouldn't have to give these other medications. And then the question is, does she need steroids or not? So there was this big trial that came out in 2002 from the Netherlands. They have sort of a good public health service, so they could follow all these folks, and it was one of the few randomized controlled trials of meningitis that we have, and it basically showed that if you gave steroids versus not giving steroids, your outcomes of all patients for unfavorable or death were significantly less. So steroids really, really helped. But then they looked at the subgroup analysis of this, and almost all of the effects seemed to be with strep pneumo rather than any of the other ones. So for example, Neisseria meningitidis, it really didn't seem like it helped. It didn't help with any of the neurologic deficits. So the classic teaching was that you give the steroids up front, but then if you identify meningococcus, you can probably stop the steroids. The steroids are more for pneumococcus. There's been some follow-up studies of that, however, that show that steroids don't hurt people, and that in bigger studies and post hoc analysis, there might be some decrease in the neurologic deficit. So I think in my practice, I would probably just give the steroids. It's 10 mgs of dexamethasone Q6 for 4 days. So I think the risks are pretty low, and you might get some extra help with some of the complications. The treatment is only for 7 days, which I think is amazing. And no matter what you do, even if you do it all right, about 10% of people won't survive, and another 20 will have bad outcome neurologically. So what's interesting about this bug also is that about 10% of us carry it in our noses all the time, and the immune system just has a way of dealing with it. But then as it changes its sugar coat, it can all of a sudden cause outbreaks, and so that's why you hear about outbreaks on college campuses in people that may not have much natural immunity. This is one question I think commonly comes up for people when there is a meningococcus outbreak, is what sort of prophylaxis should be given, and so it sort of says, quote unquote, close contacts. So this guy would be a close contact. He's like right in that person's airway. Somebody being sort of in and out of the room a couple times with the patient would not be considered at risk, but a roommate who was like living with the patient would be considered at risk. I can tell you, with this lady, I was in and out of the room a couple times. I did not intubate her, and I did take the ciprofloxacin because I don't know. I think the downside is pretty low, and it wasn't worth the worry. And for kids, you can give ceftriaxone, although I'm certainly less familiar with kids. But Cipro, I think, is probably the easiest way from the infection control perspective. The other thing I've been hearing a little bit about lately is that, so there is this meningococcus vaccine. It's got the 4 most common serotypes in it, A, C, W, and Y. It's very protective in big trials, and so they recommend that you give it to teenagers, basically with the notion that you want to give them protection as they go into their communal living situation in college. More recently, there's been meningococcus B, which is now one of the more common causes of meningococcus because there's no vaccine for it. So they just came out with a vaccine for it, and it's FDA approved for very young, very old people at risk, and even teenagers, but it's, and this is sort of a semantics thing, it's not recommended by the American Council on Vaccines because there's not very much safety data with it yet, and I just thought this was interesting. This is off the meningococcus B vaccine website, where they're basically saying if you're very young or over 65, you would qualify for this and you should consider it. What they're showing you is a picture of a teenager. So what they really want is for you to give it to teenagers, even though it's not recommended for that yet. I think probably it will be eventually, but anyway, just funny. This is mostly just minutia, but sometimes it shows up on boards exams. So if somebody has a second episode of meningococcus, the classic teaching is that it's a terminal complement deficiency. So if they have a family history of meningococcal disease and then they get it, or if they have had more than one episode, checking their complement levels would be important. So these were our learning objectives. I'll let you review those. You have the slides. So moving on, this is case 2. 66-year-old who comes in with 3 to 4 days of just some malaise, then chills, and she wasn't eating very well, and then on the day of admission, she just didn't wake up. She went to bed early the night before, and by noon the next day, she was just sleeping peacefully, just asleep. So her mother tried to wake her up, and when she tried to wake her up, she was clearly confused. And so she didn't have a lot of past medical history, but she did have a fever and was tachycardic and was altered mentally and had some nuchal rigidity. So she had a normal head CT, which was done because she was altered, and this was her CSF panel. No glucose. Her white count was elevated with PMNs and a high protein. So again, we're in the bacterial meningitis place, and this was her gram stain. And in this gram stain, you can see, it's a little bit zoomed out, but you can see 2 purple bugs that are together. So those would be gram-positive diplococci. So do you want to, at this point, keep the vancomycin, ceftriaxone, ampicillin, dexamethasone going, just ceftriaxone, dexamethasone, just ceftriaxone, or vanco, ceftriaxone, and dexamethasone? So this is a question about basically what is the treatment for Streptococcus meningitis. And for sake of time, we'll just move on. So the correct answer here is D, and ceftriaxone is about 90% effective for pneumococcus, but there's 10% of the bugs that are resistant to it. And since you don't have time to be wrong, the recommendation is to give vancomycin also until you sort of get your sensitivities back. But as I mentioned earlier, ceftriaxone really is your best bang for your buck and most effective. So treatment for pneumococcus is about 10 days. Once you get the sensitivities back, you can narrow down to ceftriaxone or even just good old-fashioned penicillin. Even if you do everything exactly right, this is a bad enough infection that about 20% of people don't make it. So all the more reason to be as aggressive as possible. These are some of the newer studies. They're looking at, can you shorten treatment? And they had some relapses when they tried to shorten treatment, so I would not recommend shortening less than 10 days. That was in kids. They tried a hypothermia protocol, kind of like cardiac arrest, and they actually saw increased mortality with hypothermia and meningitis, so that's not recommended. There's always been a concern about, does the dexamethasone decrease the inflammation at the trade-off of letting less drug into the brain? Because when there's inflammation of the meninges, the drugs get in better. And so this was a longer-term study that said, do these benefits last? And they do. So in the group of people that were in the original study, they followed them out, and the mortality benefit persisted out 20 years. So basically, do it. And then this was one where, looking at that same notion, are the vanc levels adequate if you give steroids? And it turns out they're lower, but they are still therapeutic. So again, just sort of shoring up that idea that steroids are helpful. So this is the same case, but this is a hypothetical question now. So same lady comes in with bacterial meningitis, but what if her gram stain was negative, and what if the culture was negative? So how good is a gram stain? So these are some numbers here from a review, and basically you can see that CSF gram stain for any organism, for strep pneumo it's pretty good, 70%. Meningococcus, a little bit less. For listeria, it's not very good. So that sort of brings up our first sort of foray into this new technology that that we just started with, which is a PCR platform. Our PCR platform here looks for these 5 organisms, So you'll notice that the sensitivity of these is all higher than for a gram stain. But we don't actually know how that's going to play out in practice, and we'll talk more about that. But you would be able to look for DNA of these 5 organisms in that platform. So here are the take-home points for strep pneumo. For the sake of time, we'll move on. So 64-year-old man, he came in with 1 week of headaches, some confusion. He was wearing shorts in Iowa in December and just didn't seem totally oriented. He was otherwise very healthy, high-functioning 64-year-old. Mildly febrile, he was definitely confused. He had a normal head CT because he's over 60 and he's confused. There wasn't any mass. So his CSF showed 93 cells, but they were mostly lymphocytes. His glucose was normal, protein was just a little bit high, and he had a little bit of red blood cells. His gram stain was negative, so a whole bunch of sendouts got sent. The sendouts right now for CSF, they go to Mayo. The courier leaves at 2, and they take about 48 hours. So if you do your lumbar puncture at 3 p.m., they don't go out until the next day, and then they take 48 hours. So it takes about 72 hours, depending on the time of day, to get your results back for the spinal fluid. The types of sendouts you might be doing would be something like an HSV PCR or an Enterovirus PCR. So for that reason, this is the new technology that we now have. This is a BioFire meningitis encephalitis panel. We went live with this on January 6th. And this is the same PCR platform that we've been using for our respiratory virus PCRs and also our GI panel, which went live a couple months ago. So this film array, they tested it for 17 different targets, but we're only using it for 14, mostly because those other 3 had too many false positives. So the benefits of this is that it's the same PCR type testing that we would get with sendouts, but we're going to be able to get that back in 2 hours instead of 2 to 3 days. Also, the amount of CSF that we need for the initial testing is much less. When we do sendouts, they need more so it can kind of make the journey safely. And it's probably not going to be as affected by antibiotics ahead of time. So our hope is that it's going to be more sensitive. Now, the downside of that is that it may be too sensitive. So I don't think we really know what's going to turn up yet. Like if we start finding, people with more than one thing or things that we weren't expecting, there's very little data about this test. So there's really only one published study in PubMed, and then the rest of the data about it is all proprietary. So I think there's a lot of inferred information about how PCRs work and how they're very specific in general. But I think we've seen with our GI panel that maybe it's too sensitive, like we find a lot of astrovirus, and we don't even know what astrovirus does. So I think this is something that's just going to take some time as we use it to get more familiar with and see how it's most useful. But for example, EBV, we all carry EBV once we're infected. And so the initial studies of this showed that many people when they're sick have a little bit of EBV in their spinal fluid. And what do you do with that? I don't think anybody knows, so they just stop reporting it. So anyway, so one question I had, because one of the things is that it tests for is a Parechovirus. I think maybe our pediatricians know more about this than I do, but basically this is a systemic viral illness that makes kids really sick. It's kind of like Enterovirus, but it also leads to an encephalitis-like thing. I think what will be interesting is what if we start finding Parechoviruses? I think, I don't know what to make of that, and I think we'll learn more over the next 5 to 10 years as more and more of these PCR platforms are being run, and hopefully we'll get more data. But right now, there's really not a lot of information. So how would I use this test? What I would recommend is get your usual lumbar puncture. You think they have meningitis, you get a lumbar puncture, and I would look at all of the usual parameters. And if it looks like they have meningitis based on the usual parameters, then I would look at your gram stain. Because if your gram stain's positive for meningococcus, you don't need a PCR test to tell you they have meningococcus. Or if it's streptococcus, you don't need that information. But if your studies show meningitis and your gram stain is negative, I think this is a good next step because we know that the gram stain isn't perfect, the cultures aren't perfect, and you might pick up something sooner, which would allow you to narrow your antibiotics a lot sooner. I really appreciate Microlab coming through for me. These were the cultures that have been done here over the past year. And you can see that we do a lot of cultures essentially get done on every lumbar puncture. So I think pretty much we did 188 lumbar punctures. And then of those, we only had, according to our review, one positive gram stain, which I think was our pneumococcus case. So one case of pneumococcus last year, that at least at this sort of review of our data found. And then we found a number of Enterovirus, so 9 positives, 1 varicella, and then no HSVs, although I know we had one. So I don't know if this caught everybody, but anyway, so you can see the most common thing we find of all of these is Enterovirus, which we'll talk about. So HSV encephalitis, which our patient ended up having, is a really serious illness. If you don't treat it at all, the mortality is 70%. With adequate treatment, the mortality goes down to 20%, and then almost 40 to 50% of those people end up having poor neurologic outcomes, or at least some sequelae of their infection. So the treatment is really aggressive. You give acyclovir for pretty much 2 to 3 weeks. One thing to pay attention of with acyclovir is it does form uric acid crystals in the kidneys if it gets concentrated. So I think our guy, he sort of initially woke up, but then he started to get somnolent again, and so he wasn't drinking at all, so he got dehydrated and he did get some AKI. So paying attention to their hydration is important. There's been other studies that have looked at does keeping these folks on valacyclovir over months and months help them with their neurologic recovery, and it does not. So really, you have this window to treat them, you treat aggressively, and you hope that they end up in the right category. There's an ongoing study that is not published about the use of steroids in this circumstance. I don't think anybody really knows the answer to that. The theory is that a lot of the damage that's being done is immune generated as the immune system tries to fight the HSV. So if we shut that down, can we help? But the trade-off is that then you leave the HSV to run wild because you gave them steroids. And so I don't think anybody at this point knows if steroids for this severe of an infection is a good idea or not. It might be something to think about if you're having incredibly high inflammatory markers, like it's looking like you have a huge inflammatory response and they're doing poorly. You might consider using steroids, but that's not data-driven at all. The other thing that HSV can cause is just a benign meningitis that can be recurrent. You may have heard Mallory's meningitis. Folks will show up with kind of just like cold sores. They kind of come on and then they go away. But this is caused by HSV2, not HSV1. And actually, if you did nothing, they'd probably be fine. But treatment probably decreases their frequency of symptoms. But putting these folks on, there was a study that if you put them on valacyclovir all the time, kind of preventative, like for genital herpes or oral herpes to try and prevent it, it doesn't work because the levels with oral valacyclovir at the typical prophylactic doses just aren't high enough. So in general, long-term prophylaxis, at least at usual doses, is not recommended. I do have one guy that does have this that I have on some higher dose valacyclovir prophylaxis, and I have to watch his kidney function more closely, and so far he's not had any recurrences. So, okay. So, next case, this was a 26-year-old lady, 3 days of headaches. Her children had had some GI illnesses. She had had a bunch of antibiotics, so amoxicillin and azithro, then currently on Cipro, and then came in with some photophobia and meningeal type symptoms. She did not get an LP because all she had was meningitis and she didn't have any other risk factors for having mass effect, so she didn't need a CT. And then her LP showed a lymphocytic predominant with some protein and glucose normal and then some RBCs. So I think she, because it's PMN predominant, was started on bacteria type coverage. Her gram stain was negative. She did not get steroids, and her cultures are pending, and all of these send-outs got sent. So I was nervous about her because her studies weren't classic for a bacterial meningitis. Her protein was normal, her glucose was normal, and she'd been on all these other antibiotics, and I was worried, were we missing something? So I ended up getting an MRI to look for a parameningeal abscess, which might be one cause of low-level inflammation that isn't classic. Like if you look at your meningeal studies and it's not like overwhelmingly bacterial, but kind of looks PMN predominant, you should think about an abscess. So I got that in her, which was negative, thankfully. And she ended up being in the hospital for 3 days. And after 3 days, the send-out finally came back, and it had this enterovirus PCR positive. So she was one of our 9. So this is an example, I think, of where this newer platform might really help us. If we had this enterovirus positive PCR from the get-go, which makes sense because her kids had a GI illness, like it all made sense, we might have avoided a lot of antibiotics, a lot of extra imaging, and a lot of time in the hospital potentially for her too. So I think in the end, this test is going to be helpful for that reason. I did ask, the test itself costs about $1,500, and we get reimbursed about $600. So it's not cheap, so you don't want to just do it for no reason, but there are sort of cost savings that might go with it too when it's positive. The other learning point on this case is that acutely, viral meningitis can be PMN predominant. So in her, she had neutrophils. Classically, those are bacteria, but if it's a virus and it just started, that can be viral disease. So this is our most common cause of viral meningitis. It can turn into encephalitis, which I think raises interesting questions. If she came into the ED, we got this Enterovirus PCR back immediately. There's no specific treatment. She was looking fine. She might be able to go home if she looked good. On the other hand, these people could get sicker, so it might be worth admitting for observation just for the night to get a sense of their course and how they're going to do overall. Because it can get very severe, and if it's really bad, you can try IVIG, but that's sort of a Hail Mary. Okay, case 5. I want to blow through this one. This was a bone marrow transplant guy that I saw last year. He had almost no immune system to work with, and he was being treated for a UTI, and he had some fevers, and that was it, and we were consulted to look at some resistant E. coli, but he was having these subtle word-finding problems, and his wife thought that he was having memory problems. So we got an MRI, which showed basically inflammation throughout his brain. His LP had just a little bit of lymphocytes, and his adenovirus PCR was through the roof. So he was having hematuria from adenovirus, and then this. And so the reason I bring this case up, we treated him with cidofovir, and he got better, which was probably just luck. But is the difference between meningitis and encephalitis, which is a subtle difference, but just to make the point, meningitis is photophobia, headaches, fevers, stiffness, but no mental status changes. Encephalitis, really think more about mental status or focal neurologic deficits. And if you have both, then it's meningoencephalitis. In his case, I think the adenovirus was doing the damage itself because he had no immune system. I had another guy right at the same time, a ophthalmologist who sort of ironically got a really horrible adenovirus conjunctivitis and then got a acute demyelinating inflammatory syndrome in his brain that for all the world looked like it was encephalitis. It was brain inflammation, but it was completely immune driven. So for him, he got heavy steroids and intrathecal methotrexate to shut the immune response down. So it's really sort of a balancing act between killing virus and killing the immune system if it's overacting, and you kind of want that baby bear, not too hot, not too cold sort of thing. So this patient is an interesting guy. He's a professor at ISU, and he had headaches, he had a rash, and then started developing sort of perineal numbness, almost like a Cauda-Equina type syndrome. And so he came in, he had lymphocytes, and ended up having varicella zoster, and that was all sort of already figured out by the time I saw him. But he ended up getting this progressive, terrible ataxia, even though the virus seemed like it had been treated for a while. And so we ended up giving him steroids. So this is back to that same notion of, I think this was probably his immune system overacting and causing a myelitis. So VZV, this is our one VZV from last year. He's now almost completely recovered, but it's taken months, just like shingles. You know, the pain from shingles takes months to respond. I think his course has been pretty slow to respond also. So for VZV, the treatment is the same. It's just a little bit shorter. You can try some steroids, and there's all these other potential complications, but there's no trials really telling us what to do. This case I'm going to skip over in the interest of time. This was a lady that came in with nausea, vomiting, headaches, and fevers. She had recently had a spinal procedure, and so I was worried about fungal meningitis. So just remember that if people have had a recent procedure, you have to think more broadly. There's this outbreak from contaminated steroids from people that got epidural injections. She ended up having completely negative lumbar puncture. So the point here is it's okay if you think somebody has meningitis to get the test, and if it's negative, that's okay. It's sort of like, I think about surgeons and appendicitis. It used to be that if you never had a negative appendectomy, that meant you weren't doing enough of them. I think the same is true for lumbar punctures. It's okay to get negatives every once in a while. So then there's plenty of infections that cause bad headaches, fevers, and no meningitis. And so for her, she had Norovirus, which is sort of the winter vomiting bug, which is what she basically had. This case was a pathology resident who came in with sort of low-grade fevers over several days. He worked all the time, so he didn't go out much, but he basically had a meningitis syndrome, and it was a lymphocyte predominant with a negative gram stain. And if we would have done a biofire for him, it would have been negative. And so what happens if you kind of do your usual workup and you don't find anything? Well, that's when you go back to knowing your OATS. So he was a pathologist, so did he have exposure to brucella? He had a dog, so did he have leptospira? He enjoyed golfing, so could this be West Nile virus from mosquito or Lyme? He hadn't really traveled. He was very monogamous. That makes STDs less likely. So then, based on those things, we did get a West Nile IgM, which was negative, and his Lyme IgM was positive. So Lyme IgM in the CSF is probably the best way to get at Lyme disease. This is a dime. These are the ones that bite you for Lyme disease, and so they're very, very small. So most people don't see the tick, and 30% of people don't get the rash. So Lyme in Iowa is not a lot yet, but it's increasing as the weather gets warmer. So I expect we'll be seeing more Lyme meningitis and radiculopathy over time. The treatment is ceftriaxone for meningitis. And the last case, because I'm running late, sorry, I think this is a very interesting one. 52-year-old lady who operated heavy machinery. 2 years ago, that she went to Arkansas and she was digging out these hog sheds. She came back and she had these pruritic bumps. She'd been staying in a trailer. Kind of see these sort of classic breakfast, lunch, and dinner from bed bugs. It took a little while to figure out that she had bed bugs, but ultimately somebody thought of it and she was treated. But because she had been sleeping so poorly from the itching, she started to get some headaches. The headaches just kept getting worse, and then she passed some flatworms in her stool, so she probably picked up the pork worm while she was digging out those pork things. So then she got treated for that, and around the time that she got treated, her headaches got worse. I mean, she was just having headaches. And so she made this connection that it was the tapeworm migrating to her brain that had caused her headaches. And now she sort of developed this syndrome of hearing movement inside of her head and scratching noises and really believing that something was eating her brain. And it was really amazing. She could open up her mouth and you could see her eustachian tube entrance, and she was convinced that those were burrow holes from these worms. And when they would try and treat her empirically, she was treated multiple times before I saw her, her belief was that the worms would crawl into her throat to avoid treatment and then crawl back up again. So you kind of see where I'm going with this. She had 9 O&Ps, a number of blood studies, multiple MRIs. She brought in multiple skin samples and sputum samples looking for organisms. They're all negative. It's hard to blame her. There's all this popular media about different parasites that can invade your brain and cause problems. I would really recommend this article. This is fascinating if you have time. It's long. But so anyway, where I'm going with this is that she had delusional parasitosis. And this is an incredibly difficult condition to treat and probably has a similar level of morbidity and possibly mortality as some of our worst infections. Many of these folks end up committing suicide because they believe they have a parasite that nobody can find. These beliefs aren't falsifiable, so there's no testing you can do to convince them otherwise. And you can see many of these people have moderate to major effects on their social lives, losing jobs, and this lady was an incredibly kind, warm-hearted person and had actually isolated herself from all of her family because she did not want to give them her parasite. So the treatment is antipsychotics and infectious disease. We do our best to kind of support that notion and try and move people in that direction, but less than 10% of people ever accept treatment. So it's a very challenging condition. So with that, that's the end, and I'd be happy to take any questions. Sorry, I went a little long. Oh, yeah. Yeah. I don't know. Presumably, though, the infection lives in the neuroganglion, so I don't think that the systemic PCR is going to be as sensitive as a CSF PCR. I don't know any studies that have looked at somebody that has VZV meningitis or HSV meningitis and they got a systemic one. I mean, that's one option for the evaluation in the guidelines, but I don't know any data about that. One important point that you guys might run into is that because HSV is such a severe illness and because there's often bleeding associated with it in the CSF, there's inhibitors in blood that make a PCR falsely negative. So if you have a high pretest probability, like somebody's having temporal lobe type seizures, or you see temporal inflammation, and they have a lymphocytic CSF, and your HSV is negative, the recommendation is actually to keep treating and then repeat testing in 4 or 5 days. And I think that's something that could potentially be missed, because it's like, oh, it's negative, we're good, but if your pretest probability is high enough, a negative test only gets you down so far. Okay, well, I'd be happy to take any questions down here, or if there's another one, but okay. Thank you.